This is case of the day, the last case of the week. So we're on the 132nd case. I mean, who knew we would actually get this far? But it's gratifying. And today's topic is the crazy alveolar filling pattern of this condition. And this case I've put up because I got the follow up today. Though this is a 1 year old case, and that counts as well. It's when you come to know. And so this 48-year-old came in Jan 20. So the patient is now 53, history of diffuse lung disease since 2014, variably treated as hypersensitivity pneumonitis and a couple of other diagnoses. In Jan 20, the patient had fever, non-smoker, no connective tissue disease, and we can see the consolidation, which was eventually proven to be TB. But the basic pattern is there of ground glass and septal thickening together, simulating a crazy paving appearance. And if you look at the new guidelines, then that is an alveolar filling pattern when we have consolidation, ground glass, septal thickening, and given these conditions, it's definitely not organizing pneumonia, RB, ILD, AMP, etc. It really just fits into the rare alveolar filling disorders here. Now, you could use this flowchart that I had created, which I first introduced when I did case of the day 27 or diffuse crazy paving, and this was pulmonary edema. And if you look at this chart here, since what we have is classic crazy paving here, then you would basically say that it's reasonably symmetric diffuse, there is subpleural sparing, and so this would fit into pulmonary alveolar proteinosis. That diagnosis had also been given in one of the reports issued on one of these scans, and so the patient was followed up that year during COVID with two other scans to just show that the tuberculous lesions had regressed. Then there was another scan in June 21. There was stable disease. So generally waxing, waning, stable. That was where it was. Then in 21, a TBLB was done, reported variably as ILD at one place and hypersensitivity pneumonitis at another. She's always been symptomatic, came in August 24, had a CT scan done, and at this stage, all these scans came to me for an opinion. And the only concerning thing here was that the subpleural sparing had probably increased a little with retraction. I was wondering whether there was an element of fibrosis happening because some of these patients can very rarely go into fibrosis. So we called it long-standing pulmonary alveolar proteinosis. At this stage, the patient had a lavage. It confirmed PAP, but further subtype testing has not been possible. And so today, when I had an alert that showed up this case from last year when I'd done the um, opinion, I think about couple of days last year in November, that is somewhere around the 10th or 11th. So I just checked with the pulmonologist to confirm the diagnosis. And about 3 or 4 years ago, I'd done case 26 when we had just started at ctchestreview.com and talked about pulmonary alveolar proteinosis, which has three patterns. The primary, where we have macrophage and neutrophil dysfunction due to GM-CSF abnormal signaling, which can be autoimmune or hereditary, then secondary due to other causes, and congenital, which is abnormal surfactant production. Now, this was primary. This was a patient on sirolimus post-renal transplant who developed secondary alveolar proteinosis. This was another patient with CA breast who developed diffuse lung disease and was proven to have both MTB and pulmonary alveolar proteinosis. And this patient landed up with PAP as a, we don't know what it was that caused it, but the patient had absolutely normal lungs on a CT scan done about a year prior and then landed up with alveolar proteinosis. And this was the post-lavage hemorrhagic fluid. So PAP is an alveolar filling pattern ILD. That's where it gets slotted, but usually has a straightforward appearance of a diffuse crazy paving pattern. And when you see it, as long as it's not acute, with pleural effusion, in which case you think of edema, or multifocal multicentric, where you might think of other infections or lymphoma, you should be able to make the diagnosis reasonably easily. I'll see you next week. WhatsApp channel. Thank you so much for viewing this. Good night.